Hi, Charlotte. Thanks for coming. So we are recording this, but don't feel like you can't kind of ask questions and stuff throughout. So I'm going to talk to you about some neurology stuff that's really important for exams. And as Anish said, at least you'll get some good one-on-one teaching, which you don't usually get in fourth year. So there are elements of kind of interactivity in this, but I know that it can get if it's just kind of one person, then it's all can be a bit awkward to interact. But just chip in wherever you can. So we start off with this case. So Mr. Roberts, who's a 56-year-old man who's brought in by ambulance with a sudden onset, dense, right-sided hemiparesis and difficulty speaking. So by the end of this presentation, what I want you to be able to do is answer these 4 questions. So what are you going to do with this guy? What are your differentials? How are you going to prove or disprove each one? And how are you going to follow him up? But the question I want you to think about first is number 2. What are your differentials? So Charlotte, feel free to unmute or to type in the chat what you think could be going on with this guy.
So can you hear me?
I can.
Yeah. So it could be a stroke.
Yeah.
It could be, so I haven't really done neuro yet, so it's
That's
still
cool.
relatively new. But maybe brain damage, so like due to trauma or head injury, maybe a brain tumor as well.
Yeah. Cool. Those are really good suggestions. Now I really don't like this, but have you heard of the surgical sieve?
I have, but I'm not really too sure about what it is.
So the surgical sieve is I think it's like vitamin D something, but it basically gives the causes, a couple of things to think about when thinking of causes of something. So it's like vitamin D, so vascular infectious, trauma, a couple of other things. So just have a look at it. But yeah, pretty much any kind of cause of brain damage. So one of the differentials would obviously be stroke with an acute hemiparesis. A really important differential is hypoglycemia. Hypoglycemia can cause any kind of random sort of focal symptom. And the rest of these, and you mentioned some of them, so things like brain tumors and infections can cause a similar presentation. So when you see somebody, when you see somebody like a patient with these symptoms, or you're presented with a case like this in your OSCEs or in your writtens, then it's worth thinking about all of these different things that could be causing the picture that you see in front of you. So the focus of this presentation is stroke. So I'm going to talk to you mainly about stroke, but do have the rest of these things in the back of your mind as we're talking about stuff. And I just want to draw your attention actually to the last bit, which is a functional neurological disorder. This is basically a term used for when you can't really explain the cause of particular symptoms. And I think it's about 20% of 20% of stroke-like symptoms are never, the cause of them is never found, and we put them down as kind of functional things.
Or if you go to Queen Square, 100% of what you will see.
Yeah, all that, yes. Queen Square, everyone just has that functional stuff, and no one can get to the bottom of it. So this is just my nice title slide, Strokes with Both of Us. So just a bit of an introduction. This bit I'm just going to talk at you. But basically, a stroke, as you are probably aware, is a sudden interruption in the blood supply to the brain. And for obvious reasons, that causes all kinds of problems, mainly because you lose an incredible number of neurons with every minute that passes that the brain is starved of oxygen. And therefore, it's really, really important you recognize strokes quickly and that you treat them promptly. Which is why I'm really glad that the first thing that jumped out at you with that scenario was stroke, because it's the most important thing to treat, aside from hypoglycemia, because it's really easy to treat. And in the UK, just a bit of epidemiology, incredibly common, almost 100,000, over 100,000 cases per year. So that's 1 every 5 minutes, and over 30,000 stroke-related deaths per year as well. Now, your strokes can be of 2 varieties, and the ischemic, so 90% of them are ischemic, or hemorrhagic, so you can have bleeds in the brain. I'm going to focus mostly on ischemic strokes today. I do have a bit on hemorrhagic stroke. If I get to it, then we can talk about that. If not, then I'll cover it in another session. By the way, feel free to put your hand up or interrupt me at any point if you have any questions.
just interrupt. Hands up is unnecessary with
Oh, there's only one
right?
person. Yeah. And so
Yeah,
just interrupt or type in the chat. So how do you recognize a stroke? Well, you would have heard of FAST, so face, arm, speech, time. That's what we usually use in the community to see whether somebody could be having a stroke. It's considered positive if there's either a facial droop, kind of like weakness of the arms, meaning that people can't raise up their arms and keep and hold them there, or if they have a speech disturbance. So that's what you do in the community. But in hospital, what NICE says is that you should use this score called ROSIER, recognition of stroke in the emergency room. You don't need to learn this score. I've just put it up here for interest, and so you can see what kinds of things might make you think that somebody's having a stroke. Again, a score of over 1 is positive if they have any of these things. So asymmetrical facial weakness, arm weakness, leg weakness, speech disturbances, or visual field defects. The real reason I put this in is because actually it shows you what makes the diagnosis of a stroke less likely. So a loss of consciousness or syncope, or seizure activity. So those two things do make stroke a bit less likely because strokes are usually very focal events in one part of the brain rather than global insults. There are some exceptions, like some of the hemorrhagic strokes can of course lead to things like seizures. But this is generally, I think this kind of holds true generally. So what are you going to do with this guy who's just come up to A&E and you're seeing him for the first time? Like anything in medicine, if you're asked for the management of anything, the first thing you're going to do is a quick A to E. Make sure that he's stable and that you're not missing anything that could be easily treated. So while I'm talking, I just want you to think about in your A to E assessment, what sorts of things could we come across that we might want to treat so that we keep him stable? So you can either shout out at the end of this slide or pop those answers in the chat. Immediately also, we want to check a blood glucose. We want to check that he's not hypoglycemic, and consider any other of those stroke mimics. So things like, oh hi, Izzy's here as well. So things like stroke mimics, seizures, etc. You want to take a really careful history, do an examination, and do a non-contrast CT head. So there are a couple of questions in here. So if you don't mind, Charlotte, do you want to unmute and we can talk about a couple of these points?
Yeah.
So first, yeah. Sorry, carry on.
So in terms of the ABCD, the ATE approach, sorry. So the issues that need management is like obviously the airways, breathing, circulation. So make sure that that's all intact. And then in terms of a history, you could ask about family history or past history. Has he had a stroke before? Examinations, I suppose, could you do like an upper limb, lower limb examination and maybe a cranial nerve exam? And then the non-contrast CT head, is that to look for like any bleeds in the brain?
Yeah, exactly. So well done. Those are all great suggestions. So exactly like you said, A to E approach to get, to stabilize anything immediate, like a compromised airway or anything like that. History, exactly what you said. So you want to know about family history, about a history of strokes. You might also want to gather some general past medical history, so things like hypertension, diabetes, which can predispose you to strokes. Also about medications. Are they on any blood thinning medications? Anything like that. You might also, well, actually, you do need to ask how long it's been that they've been having these symptoms, because that will change your management in the future. Examinations, exactly as you said. So you want to do your full neuro, so cranial nerves, upper and lower limb. You might also want to do a cardiovascular exam. So have a think about why you might, just keep that in the back of your mind, because I'm going to come back to it later on. You might want to do a cardio exam. And as you said, a non-contrast CT head is for looking for a bleed and excluding a bleed. Some people think it's for looking for a clot, but that's not the point of it. The point of it is to make sure that there's no bleeding. So on the scan, you might see an area of infarction. You rarely kind of see an actual clot if you haven't used any contrast or anything. But yeah, well done. We don't use things like MRIs because they take long to do. They take like half an hour as opposed to 5 minutes.
Can I just ask a quick question?
Yeah.
So why is like the airway an issue in the context of stroke? Do you have any idea, Charlotte?
Is that like if part of the brain is affected, then it can cause problems with breathing, so like the respiratory system. But that, I know that's a really like vague answer.
I mean, no, it's vague, but it's also correct because someone with like if you have a major stroke, you can drop your GCS, which means you're likely to uptund your airway. And then people with strokes can also lose things like swallow, so suddenly they have an unsafe airway as well. So like you are absolutely correct, yeah.
Yeah, thanks, Anish. That's an important point. So yeah, no, airway is really important in stroke for those reasons. Now, I'm not going to go through this in great detail, but just a bit of a throwback to second year and a bit of this year's neuro in terms of what the functions of the brain are. This is useful to think of when you're looking at strokes and what parts of the brain are affected. So these are all basically all of the lobes and their functions. So I'll leave you to have a look at that in your own time. I'm sure that you know most of these anyway. The main ones that I want to draw your attention to are the frontal lobe and the parietal lobe. Because the frontal lobe, if you remember, houses your motor cortex, which is located here where my red pointer is, and your parietal lobe houses your sensory cortex, which is here. And if you remember...
I don't think I can see the red pointer.
Oh, can you not see it? Anish, can you see it?
I can actually.
I think some people have like a different version of Teams.
Oh, okay. Well, that's all right. I can highlight.
Thank you.
Can you see that?
You see the pen?
No, I don't think so.
All right, that's cool. No worries. Anyway, I don't need to point to that many things. But just know that in the frontal lobe, you've got your motor cortex, and the parietal lobe, you've got your sensory cortex, and your temporal lobe, you have things to do with language. And we're going to touch on that later and why that's important. And now we come to, so that's kind of the main bit of the brain. And now hi Celia, we've got someone else joining, the functions of the brain stem and the cerebellum. So I'm not going to ask you to tell me all of them, but basically the brain stem is there to support life. So it's got our respiratory centers and things like that in there. And the cerebellum helps to coordinate movement. But in addition, and this is quite important, this is very important when thinking about strokes, the brain stem contains the nuclei for all of the cranial nerves. So all of the neuroanatomy that you learned in second year, luckily you don't need to know it in as much detail this year, but it does help to have a brief understanding of what comes out where. So generally speaking, so you've got 12 cranial nerves. 2 come from above the midbrain. So that's cranial nerves 1 and 2 come from above the midbrain, the olfactory and the optic nerves. 3 and 4 come from the midbrain themselves, so the oculomotor and the trochlear nerve. And then the rest of them, the next 4 come from the pons, and then the next 4 come from the medulla. So that's quite useful to think of when thinking of strokes. And again, we'll come back to this in a bit. So you've got 4 cranial nerves coming from above the pons, 1, 2, 3, and 4. So 1, 2, 3, and 4. In the pons, you've got the next 4 cranial nerves, and in the medulla, you've got the next 4 cranial nerves. And then the cerebellum is important for balance and movement. And you might have come across this previously, you might not have. But if you have any damage to the cerebellum, then you get these symptoms. So you can remember it by Danish. So you have your dysdiadochokinesis, so you can't do repetitive movements like this. So when you do your neuro exam, that's what you're asking them to do. You get ataxia because people can't coordinate their movements properly, and that means that Romberg's test will Romberg's test won't be positive in a cerebellar stroke. I don't think.
It's just a dodgy image of Google.
Yeah, it's a dodgy image of Google. Ignore the Romberg's bit. You get nystagmus, so rapid eye movements, and that's why you do the H test in your cranial nerve exam. because you're looking for, first of all, you're looking for eye movements. Secondly, you're looking for any nystagmus. You get an intention tremor. So if you ask them to touch your finger and then touch their nose, then they get an intention tremor and maybe some past pointing as well. Slurred staccato speech and hypotonia. So the reason I put these up is we often think of strokes as sort of arm or leg symptoms, or facial symptoms, because most strokes do happen in the cerebral cortex. But if you have a stroke affecting the cerebellum or the brainstem, then do bear in mind that you can get problems with any of these cranial nerves or any of these symptoms. And a real example of this was when I was at Queen Square at the end of 4th year. Somebody came in with intractable vomiting and vertigo and nystagmus. And now the only reason they came to the stroke unit at Queen Square and not to A&E at UCH and then had to be transferred is because luckily a stroke nurse from Queen Square was passing the Brunswick Centre where he had the stroke. And she recognized that actually he was having a cerebellar stroke rather than, like, I don't know, eaten something dodgy and therefore was vomiting or had any other kind of thing. So just bear in mind that strokes don't always present with your like typical arm or leg symptoms. They can present with any of these brainstem or cerebellar symptoms as well. And we're going to come on to those in a bit. Celia, hi, thanks for joining. If you have any questions, feel free to unmute. I'm going to be asking you some questions and stuff throughout. And Anush, did you have something to add?
Yeah, I was just going to mention, when you're doing intention tremor in an OSCE or just examining real patients, if you're worried that they have an intention tremor, always go finger first and then nose, because like if you go to the nose first, they're going to hit themselves in the face and they might hurt themselves, and you can lose the trust of the patient like in just a second by doing that first. So if you are genuinely considering intention tremor as a possible sign, you should start with, I mean, in my opinion, you should always start with their finger. Just never start with the nose.
I didn't know that. That's really useful. And the other thing is that you're not going to find an intention tremor if you're not making them reach far. So there's no point doing like intention tremor with your finger right next to them. You do need to make them extend their arm fully. So 2 tips for OSCEs. Okay, so that's a bit of neuroanatomy. The last bit of neuroanatomy is blood supply. So the circle of Willis is not as scary as when you first look at it, if you kind of break it down. But the main arteries that I want you to think about are the ones that have circled. So there's a dotted line halfway through the circle of Willis, if you can see that. And the reason I put that there is because for the purpose of stroke, we split the brain circulation into the anterior circulation and the posterior circulation. So the anterior circulation is anything above that dotted line. It's a middle cerebral artery and the anterior cerebral artery. And these basically supply most of the cerebral cortex. And then everything below that, so the posterior cerebral artery, the basilar artery, the anterior inferior cerebellar and the posterior inferior cerebellar arteries are part of the posterior circulation. And in the top right, I've just written that down. So the branches of the internal carotid are the ACA and the MCA, and those are the anterior. And the posterior, which come off the vertebral arteries, or the confluence of the vertebral arteries, which is the basilar, are considered posterior circulations. Parts of the posterior circulation, rather. And the reason why that's important is because we categorize strokes by whether they're anterior or posterior circulation, because that does affect how we manage them, because it affects how easily we can get to the clot if we want to fish it out. And you might remember this thing from 2nd year, which is a slice through the brain and basically a diagram of which artery supplies what. Now, what I have forgotten to do is to put on how the human body maps onto this slice of the brain. So Celia or Charlotte, could you tell me in terms of the organization within the motor and sensory cortices of the brain, where do we find the leg? Is it medial or lateral?
Medial.
Exactly. So the leg is medial, so in that kind of blue anterior cerebral artery territory. And then the tongue and the mouth is much more lateral in that kind of red, deep red MCA territory. So just bear that in mind when you have somebody presenting with a stroke. So if you've got somebody with symptoms in the right leg, what artery do you think is affected if it's the right leg?
Left ACA.
Exactly, the left ACA, because obviously the brain controls the opposite half of the body. And equally, if you've got kind of facial and hand symptoms on the right hand side, then it's going to be a left MCA stroke. And really, it's questions about stroke aren't usually much more complicated than that. And I've put in, yeah.
I was just going to say, it's like a big exam topic that people get wrong because they think it's really complicated, but this is the extent of like most of the questions. And in my year, we had something like 10 questions like this. So it's definitely worth your time. Yeah,
totally. If you don't kind of get bogged down in all of the little detail and stuff, then it's absolutely fine. You don't need to know the whole circle of Willis. No one's ever going to ask you to draw it out. And unlike second year, nobody's going to ask you, you know, what branch of this artery is it? So like, don't worry, just know ACA, MCA, PCA, and the two cerebellar, brainstem arteries I just talked about. So strokes by territory. So you've got your ACA, medial brain surface, so contralateral leg weakness and paresthesia. You don't generally get the face affected because that's a more MCA thing. And interestingly, you can get anosmia because if you remember, cranial nerve 1 is kind of an extension of the brain. It comes forward and then you get your fibers coming down through the cribriform plate at the top of the nose. MCA is the lateral brain surface. So we've just been talking about the face arm weakness. And the two other things that are put in here are quite interesting. So you can have aphasia, that's difficulty with communication. So it's not just difficulty with talking, but it's difficulty with communication. And that can extend to difficulty writing, difficulty understanding, as well as difficulty talking, if it's in the dominant hemisphere. So does anyone know what hemisphere is usually dominant in people?
The left.
Left hemisphere is usually dominant. And I mean, you'll always see on the top of neurology clinic letters, people will be like, oh, it was a pleasure seeing this left-handed gentleman in clinic today, or this right-handed lady in clinic today, because there was
weirdos.
Yeah, because they are really weird. But also, there was this kind of thinking that your dominant hemisphere will be opposite to your dominant hand, but that's not the case. Most people have a dominant left hemisphere. So if you've got an MCA infarction in your dominant hemisphere, you can get aphasia, and if you've got a stroke in the MCA of your non-dominant hemisphere, you can get hemi-neglect. So hemi-neglect is when you literally, as the name suggests, you neglect half of your body. So some people think their hands don't belong to them on one side of the body. Some people won't respond to a visual threat. So if there's something kind of coming at their face on one half of the body, then they won't respond to it. So it's really weird. And if you do get to go to Queen Square, try to find somebody with neglect because it's quite interesting to see. And then we've got the PCA. The PCA supplies the whole of the back portion of the brain. Now, what's really important with the PCA is you get a contralateral homonymous hemianopia with macular sparing. Now, I forgot to put on a picture of what a contralateral homonymous hemianopia looks like, but what it means is basically that if you've got, if you knock out your left PCA in your occipital lobe, then you will have both of your right visual fields blank, but you will have an area in the middle that is unaffected. Does anybody know why you get macular sparing? So why wouldn't it just be completely like the right-hand side of your vision, right-hand side of your visual fields just go completely? Why do you have this little spot that you can still see in the middle? And Anush, you can send a picture in the chat of, thanks. Sorry, Celia, carry on.
Is it because the fibers cross over the optic chiasm? Or because it's supplied by a different nerve? I can't remember which one it is.
You're kind of along the right line. So the fibers in the chiasm is more to do with when you got your bilateral hemianopia. But the reason that you get sparing of the macula is because the macula is so important. It's got so many nerves in it that the region of the occipital lobe that processes information from the macula has a dual blood supply. So if you knock out your right side of your occipital cortex, fine, your left visual fields will go, but your macula will be spared because you've still got contributions from the other PCA, if that makes sense. Hopefully that makes sense. Just kind of give me a thumbs up.
Thank you.
Whereas if you knock out both of them for any unfortunate reason, you get cortical blindness. So your whole occipital lobe dies. And even though your eyes are working, your brain can't process the information. All right. So
can I add one thing? Sorry.
Yeah, of course.
If you go back one slide. Just remember that you can get a contralateral homonymous hemianopia with an MCAA infarct as well, because of the radiations that go through it. The only difference is you won't get macular sparing with an MCA infarct.
And usually you get a quadrantanopia, don't you? But you can get a...
So it depends. Usually you lose both radiations with an MCA infarct. So it depends how far along the clot is. But yeah, so it depends.
So yeah, it would be useful to look up visual field defects and where lesions can cause different defects. Yeah. And if you have any questions about them, then obviously feel free to ask.
Big exam topic, visual field defects.
So that was kind of strokes in general. So we talked about presentation, the presentation of a stroke, differentials of stroke, your initial management of stroke and your initial investigations. And I said to you that there are two different types, ischemic and hemorrhagic. So for the next few slides, I'm just going to focus on the ischemic strokes. So Charlotte and Celia, could you give me some causes of an ischemic stroke?
Is AF?
Yeah, good. So how does AF cause a stroke?
Is it when an embolus gets or travels from the heart to the brain? And then...
Yeah, exactly. So we call that a cardioembolic stroke. Any other causes of ischemic strokes?
Hypercholesterolemia.
Yeah. So how is that going to cause a stroke?
An atheroma. I think it's called an atheroma.
So you get an atheroma plaque, which can either throw off clots or it can rupture and kind of block the carotid. So those are the main two, actually. There are some rarer causes as well. So thromboembolism and atheroma is number one. Then you've got your cardioembolic causes. So things like AF, not only AF, but also infective endocarditis, because you can throw off septic emboli to the brain. They can cause both meningitis and strokes, and that's just really not good. You can also have kind of, if you've got valve disease and you get clots forming on the valves or on the walls of the heart, so that's called a mural thrombus, then that can come off and go into the brain as well. And then you've got these kind of weirder causes that are important to have in the back of your mind, because when somebody comes in with a stroke, it's not just about how am I going to manage them, how am I going to kind of save their brain now. It's also asking yourself, what's caused the stroke and how am I going to prevent it from happening again? So causes like hypercoagulability, if people have issues like polycythemia, so too many red blood cells, then or thrombocytosis, they've got too many platelets, then that can cause their blood to become quite viscous. And there are other rare causes which you might see at Queen Square to do with random metabolic stuff. Things like smoking causes a hypercoagulable state as well. Vasculitis, which is Anush's favorite thing to read about, can cause vessel disease anywhere and can lead to strokes. A global insult, so if somebody has a cardiac arrest, you might not think of that as an ischemic stroke, but actually the brain is incredibly sensitive to hypoxia. And you've got these things called watershed areas, which is where the blood supply changes from one territory to another. And those areas are particularly susceptible to infarct. So if you have a cardiac arrest, or if you have sepsis or any other kind of shock and your brain has been underperfused, in kids, it's not called an ischemic stroke, but if a child is born and isn't breathing for a while, then they also get infarctions in their brain. So a global insult can cause ischemic stroke, and venous sinus thrombosis. So this is something that doesn't often come up in exams, but may be worth reading about, just to be aware of. Yeah, Celia?
very quickly touching on vasculitis.
Yeah.
That's right. Thank you.
Did you have a question?
Sorry, what was the question?
Isn't just like what vasculitis is? Is it just the inflammation of blood vessels, basically?
Yeah, effectively, you can get inflammation of blood vessels anywhere in the body. When blood vessels are inflamed, they'll narrow, and you get reduced blood supply to an area, and you'll get an ischemic event. If it happens in the brain, you'll get a stroke. If it happens in the heart, you'll get a cardiac arrest. More commonly, it'll happen in the kidneys, and you'll get like kidney disease. But like it is a recognized cause of stroke as well in the young person.
Okay.
Maybe we can coax Anish to come back and do a vasculitis teaching. But the vasculitis, so like Anish said, it can affect anywhere, and it's a core condition for rheum in Mod B, and also for renal in Mod C and for neuro. So it's one that's really, you don't need to know about it in much depth, but it's useful to know what antibodies go with which. So you might have heard of like the Churg-Strauss syndrome and Wegener's, which are now called granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. So all of those sorts of things would be worth learning about, because they do come up in rheum and in renal and in RESP, because you can have vasculitis that causes pulmonary hemorrhages, as well as in neuro and all of those. So yeah. Venous sinus thrombosis, just have a read about it. Basically, if you have a congestion of the venous system, then blood doesn't drain from the brain properly, and it can cause ischemia as well. That's a venous thing rather than an arterial thing. And very quickly, I'm not going to spend much time on this, but I wanted to talk to you about arterial versus venous thrombosis. This was Anish's suggestion to include, and I think it is really important to appreciate the difference, because sometimes you think, I saw a PassMed comment, which was from the final year, and they were like, I still don't get why people give antiplatelets and why people give anticoagulants. So you don't want to be that person. So basically, you can have two different types of blood clot. So you can have clots in arteries, and these are mainly mediated by platelets. So things like MIs or atheromas are usually mediated by platelet aggregation in arteries. And this is usually treated with antiplatelet agents. So after having an MI, people are usually put on dual antiplatelet agents. So they put on aspirin and prasugrel or clopidogrel, or one of those. The reason that we're using antiplatelets is because the main problem there is platelets sticking together. So we want to disable the platelets and stop further arterial clotting. And then on the other side, you've got your venous red clots. So you have your Virchow's triad of stasis, hypercoagulability, and endothelial injury. So if you've got things like DVTs, PEs, venous sinus thrombosis, all of those are red clots. So this is where you've got lots of fibrin. And I think included in this is the clots that you get from in atrial fibrillation, because you get your clotting of the, basically the mechanism of clotting in AF is that the blood is being agitated and not being pumped. It's static. So you have your stasis in the atria, which means that you need to, it's not a platelet problem, it's a blood clotting problem, which is why you treat AF, why you treat DVTs, PEs, venous sinus thrombosis with anticoagulation rather than antiplatelets. So you're thinking about your anti-factor 10s, your heparins, your vitamin K antagonists like warfarin for venous clots or for AF. And for arterial clots, you think about giving people antiplatelets. And if you remember those two things in your head, when you've got an exam question and you're thinking like, oh crap, am I going to give them aspirin or am I going to give them, oh, thanks Celia. Not all credit can go to me. I think Anish actually told me to include it the last minute yesterday. So, but yeah, no, it's definitely very, very useful to know. So have a look at that table. And again, any questions, please do come back to us. Right. So touching on some of the weirdest strokes. So we've talked about cortical strokes. You know that if it's the leg, it's usually the ACA. If it's the arm and the face, it's usually the MCA. If it's the eyes and you've got hemianopia, then it's usually a PCA. But you can also get brainstem syndromes. And I looked at this briefly before when I showed you the brainstem and where all of the cranial nerves come off. So I would say think of a brainstem syndrome when you've got a weird sort of pattern of sensory and motor loss. So if you've got like sensory loss to half of the face and then motor loss to the contralateral side of the body, you've got something weird like that going on, then definitely think of a brainstem syndrome. And again, your cranial nerve exam, if in somebody presenting with a weird syndrome or a weird type of stroke will go very far in helping you, because you might realize that, oh, half of their facial nerve has been knocked out, or they've got nystagmus, or they can't move their palate on one side, or they can't move their tongue. So just think of, when you're presented with a weird stroke, just think of your cranial nerves and where they will come off. Now, I've put a table down here of the brainstem syndromes. The main one you need to know about is the top one, so Wallenberg syndrome. So posterior inferior cerebellar artery. And this is where you get an ipsilateral loss of facial pain and temperature sensation, because it's not the spinothalamic tract, it's the face equivalent of the spinothalamic tract. I think it's one of the spinal nucleus of the trigeminal, something weird. And on the other side, you get limb, torso pain, temperature loss, and you also get global symptoms of ataxia and nystagmus. So what I would say is just if you take anything away from this in terms of the brainstem strokes, have a look at the neuroanatomy of this, why this stuff happens, but learn about Wallenberg syndrome, because 99% of the brainstem stroke questions will be a posterior inferior cerebellar artery. It's like that old, like the old pudendal nerve in year 2 anatomy. If you're unsure about a weird stroke, then it's the posterior inferior cerebellar artery, and you'll usually get it right. The other ones to look out for as well, the anterior inferior cerebellar artery, which is similar to Wallenberg's, but you get ipsilateral facial paralysis and deafness too. And the way I remember this one is facial paralysis, because actually facial has a CIA, but really it's AICA. That's where I remember it. I don't know if that makes sense to anyone, but it makes sense to me. This is quite important, actually. If you have a stroke in the retinal or the ophthalmic artery, which if you saw on the circle of Willis diagram comes off of the carotids, then you get amaurosis fugax, which is basically when you have, the patient will describe like a curtain coming down over their vision. So it's really important that if somebody comes to you with that, or if you see that in an exam question or in an OSCE, you're thinking, is this a stroke? Not just, is this a pure eye thing? And then you've got your other ones, so basilar artery, which can cause locked-in syndrome, and pinpoint pupils. The way to remember that is pinpoint pupils points to the pons, and superior cerebellar artery, which is just kind of random stuff, and that's a cerebellar stroke. That's why you get all of your Danish signs. Okay, I'm just going to pause there. Do either of you have any questions?
Nope.
Charlotte, are you okay? Do you have any questions?
No, that's all good. Thanks.
Great. Now you might see 40 slides on your screen, but don't worry, I'm not actually going to get through all of them. I'm mainly going to talk to you about the management and treatment of ischemic strokes. So I'll leave the hemorrhagic ones for another day. So the other thing that you can get in strokes, alongside those motor and sensory symptoms, is higher cognitive dysfunction. So aphasia, which we touched on, dysphagia. So aphasia is difficulty communicating. Dysphagia is difficulty with things like swallowing, or like the motor element of speaking, rather than the understanding and the language processing. You can also get things like dyspraxia, dyscalculia, however you pronounce that, visual field defects, and neglect, which we've touched on. So just bear those in mind. What I do want to talk to you about, though, is aphasia. I found this diagram from PassMed really helpful. You do get quite a few questions on aphasia. You could also get a speech exam in your OSCE, and it's something that you're not ever taught, something that you are expected to know. So Anish, perhaps you could pop a link to the Geeky Medic speech exam in the chat. So the way I approach aphasia is exactly like this. Is the person speaking fluently, or are they speaking non-fluently? Then can they understand and comprehend things, or can they not? If you can answer those two questions, you can get what type of aphasia it is. So brokers is when they have non-fluent speech, but they have no trouble with understanding or expressing or kind of choosing words. It's actually, it's like a motor problem of speaking. So that's if you have an infarct to inferior frontal gyrus, which is the MCA territory. But if you have fluent speech with comprehension intact, then you have your conduction aphasia, which means there's an issue in the communication between Wernicke's and Broca's area. And actually, I'm going to take a step back because I should have said this first. You have two main bits for speech in your brain, so Broca's area and Wernicke's. I've told you what Broca's area does, so it's the motor kind of center of speech. What does Wernicke's area do?
Comprehension.
Yeah, it's about comprehension and understanding. And those are both connected by the arcuate fasciculus. So if you've got a Broca's problem, you get Broca's aphasia, you can't produce your speech, but you can understand things. If you have a Wernicke's problem, you might be able to produce speech, but it will be nonsensical speech, and it will be fluent, but it will be nonsensical. That's when you have a Wernicke's problem. And you can also get this conduction aphasia, which is where you've got fluent speech with your comprehension, which is relatively intact, but you have other issues like repeating things. So, you know, if you say, you know, tell me, repeat this sentence after me, a cat sat on a hat, they might not be able to do it. And actually you can see them get frustrated because they can understand that they can't do it, but they just can't get the words out properly. So definitely have a look at aphasia and go on YouTube and take a look at things.
I was going to say people are generally really bad at aphasias, like even doctors. Just a real life story, but a couple of weeks ago, someone had Wernicke's aphasia on our ward. And I mentioned it to the consultant and everyone laughed at me. They're like, oh, Anush, you're such a nerd. And then like they went and examined him and he was having a stroke. So like it's a really useful skill to be able to recognize. And like your seniors will not recognize it because they're too specialist.
Yeah, that's a really good point. And I think like anything in medicine, try to remember the basics. I mean, one of the consultant pediatric cardiologists was having issues like dealing with an ingrown toenail. So on a child. So you know, it's good to remember the basics because you will have to help out at times. This is another thing. It's mainly exam fodder rather than things that are used clinically. Now, this is the Bamford-Oxford classification of strokes. And the reason this was created was because a group of neurologists, I think, said, oh, you should be able to localize a stroke and tell us what kind of stroke it is without the need for a scan, which, okay, is true. But I don't know whether it's the most useful thing because aside from knowing anterior versus posterior circulation, so ACA and MCA versus PCA and brainstem, it doesn't do much in terms of changing your management, but you do need to know this for your exams. So you've got your total anterior, your partial anterior, your lacunar and posterior strokes. I'm not going to read these out to you because you can read them in your own time, but what I did want to share with you, again, another one of Anush's suggestions was my simplified way of thinking about this. So I know that a total anterior circulation is, so those are mixed up actually. Bad should be on the left and less bad should be on the right. I'll correct it before I send these slides out. But a total anterior circulation stroke is really bad. It's when you have hemianopia, hemiparesis, and apical dysfunction. So you've got like an aphasia or a visual field defect or something. And then you can have a partial anterior circulation stroke, which, as the name suggests, is like attacks, but it's less bad. So you only have 2 of those things, not 3. Then you can have your lacunar syndromes, which are really focal. So if somebody has a pure motor or a pure sensory stroke, they've got just left hand weakness, but no sensory deficit whatsoever. That's a lacunar stroke. And then you have your posterior circulations, which are all weird brainstem cerebellar stuff. So all of your Danish signs, all of your cranial nerve signs, any of those just bunch into posterior. So yeah, that's basically what you need to know. I would learn this for your exams, but it's the kind of thing that you might want to revisit just before the exam because, you know, there's no point retaining this information. I certainly don't. Okay, so we've been through ischemic strokes, causes, problems, that they can, that you can see. And now we're going to go on to the complications and management before I wrap up. So I've got a couple of slides here on the acute complications of stroke. So what can happen straight away after somebody has a stroke? Anyone want to tell me what might be going on here? No worries if not. Anyone want to have a stab at it?
You can also give it a clue.
Yeah, I'm going to have a look at the, yeah, Karen, yeah, Celia.
I don't know if it's right. That and
It is. And where is it?
on the right hand.
Yeah, and is it at the top, middle, or bottom of the lung?
Bottom.
So close. So you're at the top, sort of. If you can see, I know you can't see my pointer. I will try to point again. If you can see this weird wedge-shaped shadowing, kind of towards the top to the middle of the right lung.
Oh yeah.
Yeah. So that's your pneumonia, and this has happened. So whenever you see a pneumonia in the top right, think of aspiration. If you remember from your year 2 anatomy, the right main bronchus, and also this comes up quite a lot in terms of like pneumonias. The right main bronchus, because of its shape, is more susceptible to things going down it. Like, that's foreign bodies, and when kids like swallow things and aspirate things. But it's also when people aspirate their own, kind of when they're eating and food goes down the wrong way, or they vomit and things go down the wrong way. So if somebody has a stroke, it's really, 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 really important that you make them nil by mouth, and you make sure that they have a swallow assessment to make sure that they're safe to swallow, and that the speech and language therapists, so SALT, see them, so that you can prevent this from happening. This is a leading cause of death in the acute phase of stroke. People get an aspiration pneumonia, an elderly person gets an aspiration pneumonia, they become septic, and then they deteriorate. And you could try to guard against this by making them nil by mouth and making sure that they have a safe swallow. Any idea what's gone on here? Now, this is a bit of a tricky one. The left is when the person came into hospital, and the right is 1 day after.
Is that a ischemic stroke that's transformed into hemorrhagic stroke?
Indeed, it is. So this is a hemorrhagic transformation of stroke. This is, again, a really important thing to bear in mind within ischemic. So just because you've scanned and you haven't seen a bleed doesn't mean that a bleed won't pop up in the next 24 to 48 hours. It's really important you keep a really good eye on people who have had an ischemic stroke. This is why they're usually cared for in a hyperacute stroke unit, because they can be closely monitored, and if anything's going awry, then they can be scanned and interventions can be made. So on the left, you've got your ischemic stroke. I don't know what one of the lateral ventricles does look a bit big. I'm not a radiologist, I can't tell you why that is, but yeah, there's an ischemic stroke there anyway. And on the right, you can see an area of bleeding and a big area of infarction. This is a hemorrhagic transformation. And this is important to bear in mind because we're going to come on to the management in a second. But if you thrombolize somebody, you clot bust, then obviously that impairs their ability to form clots as well. And that's your that can predispose to bleeding and strokes transform. The other reason is that I didn't know this until the end of 4th year. Statins are contraindicated if somebody's had an intracranial hemorrhage. And that means that if you want to give somebody statins after a stroke because their cholesterol is high, you have to wait 48 hours before doing it, because there's a risk of hemorrhagic transformation in the first 48 hours. And what's happened here? Left is on arrival to hospital, right is after. No worries if you don't know. So on the left, you have your normal stroke, and on the right, what you can see is that the stroke has caused, well, you might not be able to see it, and to be honest, I can't see it, but with the eye of faith, the stroke has caused swelling and edema, and that's caused, and if you say this, neurosurgeons will love you, effacement of the lateral ventricle. So it's squashed the lateral ventricle. That raised intracranial pressure is quite dangerous because obviously the skull is a fixed box, So something's got to give somewhere. If the pressure increases, there is a chance that the brain will slip down, herniate down the spinal cord. So strokes obviously can cause inflammation because you have infarcted tissue or dead tissue. And that edema can put pressure on the rest of the brain, and that's badness. You don't want that to happen. This is relatively rare, but it's important to keep an eye on. This is why people with strokes are generally rescanned. So, management of a stroke. We're almost at the end of this bit of the presentation now. So the first thing you want to do is A to E. Then, well, I think we've said most of these things anyway. Admit to a hyperacute stroke unit, screen their swallow and make them kneel by mouth. Put a nasogastric tube in if you need to. And after that scan has come back, if they don't have a hemorrhage, but you're confident they've had a stroke, give them 300 milligrams of aspirin, just like you do in an MI. But if they have a hemorrhage, don't give them aspirin because it's going to make it worse. Then you want to think about, if this is an ischemic stroke, how am I going to undo the damage or limit the damage? The main two ways of doing this are thrombolysis with a tissue plasminogen activator, so something like alteplase, and thrombectomy. This is an interventional radiology procedure where radiologists go into the brain and fish out the clot. For exams, it's really important that you know the criteria for thrombolysis and thrombectomy. So you can thrombolyze somebody if they present to you within 4.5 hours of onset. The reason for that window is that thrombolysis comes with a risk of bleeding. And after 4.5 hours, the benefits of the risks of thrombolysis outweigh the benefits after 4.5 hours because you've already lost a lot of neurons. So, the benefit is going to be limited compared to the damage you can do. Then thrombectomy should be done with thrombolysis if you've got an anterior circulation stroke and the person comes within 6 hours. So that means if someone comes in with a stroke at 4 hours, they get both thrombolysis and thrombectomy. If they come in at 5 hours, they don't get thrombolysis, but they might get a thrombectomy. And if they come like a day later, it is possible to do an extended window thrombectomy, but only if a brain scan shows that there is still living tissue that can be saved if the thrombectomy is done. So basically, the three things I want you to take away mainly are aspirin, thrombolysis, thrombectomy. And then obviously you want to do your MDT approach and your therapies assessment and stuff. Please have a read. Yeah, Anish.
I was just going to ask, so something I didn't quite understand. Often these patients might come in because atrial fibrillation is such a leading cause of stroke. So they'll come in on warfarin and then they'll have a stroke. So any ideas what you would do about their medication in that context?
If it's an ischemic stroke? Yeah,
in the context of an ischemic stroke. So they've come in on warfarin, they've had a stroke. Charlotte or Celia, any idea what you would do about their medications?
Do you stop their warfarin?
Yeah. Basically stop their warfarin because they're at risk of bleeding, because it could transform in order to a hemorrhagic one, and you're going to give them the 2 weeks of aspirin, and then you can think about starting the warfarin again. But it's something that people get wrong, juniors get wrong, and pharmacists correct them about it a lot. But yeah, really important thing to remember. So stop there. Yeah, I was going to say also first thing I do is ask Anish or a consultant. Contraindications to thrombolysis, incredibly important. I'm going to carry on for 5 more minutes, and I actually want to get to the prevention of strokes. So I'm not going to talk through all of these, but do have a look at them. So you have absolute contraindications and relative contraindications to thrombolysis. Just a couple of absolute ones. So if somebody's had a brain bleed, don't give them thrombolysis. They're predisposed to having another one. This is an important one that people don't often know about. If they have a brain tumor, brain tumors have all kinds of weird blood supplies that are prone to bleeding. Don't thrombolyze them. If they've had a stroke or a brain injury in the preceding 3 weeks, don't thrombolyze them. If they've had major bleeding, so a major bleeding like a GI bleed, they're actively bleeding now, or if they've had a lumbar puncture in the past 7 days, don't thrombolyze them because you run the risk of them bleeding into their subarachnoid space where they've had their lumbar puncture. And then your relative contraindications, and these are slightly looser. This is where a lot of the times it's actually left up to the patient, and you say to them, well, look, you've got a bleeding problem. You're more at risk of bleeding. You've had a stroke.
we can do this. The risk of bleeding is this, and the risk of you not getting better is this. And you can present them with all of the information, get some get specialist advice to help them along the way, but leave them with a decision as to whether it's a risk that they are willing to take. So definitely have a look at these. The main ones that come up in exams and in practice are brain tumours, previous hemorrhage, and a stroke in the past 3 months. So just before I finish up, so you've managed the stroke acutely, you found out why it's happened, hopefully. Now you need to prevent them from having another stroke. So you give them, this should be 2 weeks of aspirin, I think, not 3 weeks of aspirin. Well, I'll double check that before I send the slides out. But really what you want to do is you want to give them high dose aspirin, 300 milligrams for either 2 or 3 weeks. I think it's 2 weeks. And then give them clopidogrel for 75 milligrams lifelong. But if they have AF, we talked about the red clot and the white clot stuff. If they have AF, clopidogrel is not going to cut the mustard. You need to anticoagulate them. So you give them 14 days of aspirin. Yeah, it's 14 days. 14 days of aspirin, and then anticoagulate them with something like rivaroxaban, one of those DOACs, or with warfarin, if that's what you're going to use. So antiplatelets, aspirin and clopidogrel for the first 2 weeks, and then just clopidogrel, or if it's because of AF, aspirin for 2 weeks, and then clopidogrel. You also want to give them a high dose statin. So it's 2 weeks. So you want to give them high dose statin, 80 milligrams of atorvastatin after 48 hours, again, because of the risk of hemorrhagic transformation. You want to control their blood pressure. And then you want to see whether the stroke is because they've got furring of their carotid artery. So you do a Doppler and you refer them for a carotid endarterectomy if it's over 70% stenosis with this criteria, or 50% stenosis with this criteria. You don't need to know about the criteria in detail. In our exams, they didn't even tell us. They just said this person has 75% carotid stenosis. The threshold that they teach you is 70%. If they've got over 70% stenosis, then you refer them for carotid endarterectomy. But you have to be careful of which side is symptomatic. So if they've got 75% stenosis in the right carotid artery, but they've had a right-sided stroke, then actually that's not the artery that's caused the problem. Because if they've had a right-sided stroke, then whatever happened in their brain happened on the left side. So sometimes they will try to trick you out by mixing up the sides. So if you have a left-sided stroke, then you're looking at the right carotid artery. And if you have the right-sided stroke, you're looking at the left carotid artery. It doesn't matter if the other one is 90% occluded. You're only looking at the side opposite to where they've had their actual stroke in their brain, if that makes sense. Then you've got your long-term complications of stroke. So, basically people just on a general downhill trajectory, which is why you need your MDT input, including psych. And then just to finish up, we'll go back to our case. So Mr. Roberts, a CT scan showed an infarct in the left MCA, as he had both a thrombectomy and a thrombolysis because he came quickly, and he's making really good progress. But he has an ECG, and it shows this. So what's going on in his ECG? So I didn't want you to present it fully, just what's the standout anomaly?
Does he have a broad QRST?
So you might be looking at that one kind of ectopic beat on the left-hand side. Is that what you're looking at?
Yeah.
So that's an ectopic, I think. Okay. But if you look at the regularity of the QRSs, what are you noticing? I mean, this is a bit of a bad ECG for this, but basically you can't see any discernible P waves, and with the eye of faith, this is an irregular rhythm. Okay, so what's the ECG showing if I tell you there's no P waves and it's irregular? So you're looking at atrial fibrillation. Okay, so this guy has AF, so he's thrown off a cardioembolic clot. which has caused a stroke. So how are you going to manage him? And just shout out an answer.
It's okay to be wrong. It's the only way you ever learn.
Would it be warfarin sodium?
Cool. What do you think, Charlotte?
I was gonna go for A, but I'm not sure. It's just a guess.
Yeah, cool. So let's talk through these options. So A is a really good option if somebody doesn't have AF. So if this was a stroke, just because, he just had a stroke because he has really bad carotid artery stenosis and he's got, hypertension, diabetes, he would do A, totally. So 300 milligrams of aspirin for 2 weeks, then clopidogrel lifelong. C, warfarin is not a bad idea for AF, but what we like using is rivaroxaban or one of the DOACs, because they don't require INR monitoring, and they don't require you to stop other medications and stop eating spinach and stupid things like that. So B would be the most correct thing to do here. So you'd want to give him rivaroxaban every day for the rest of his life to prevent him from having another stroke from his AF. Anish, were you going to add anything?
I was going to say this is a very good example of a UCL question, because the ideal situation would obviously be aspirin 300 milligrams for 2 weeks and then rivaroxaban. But UCL will never, they do this thing where they never give you the ideal answer. They'll just give you a sequence of less bad answers and you have to pick the least bad one.
Exactly, yeah. And that's annoying, and B is the least bad one. I've got a different case, guys, which isn't too long, but if you want to leave, then feel free to. But I'm going to carry on just in the interest of the recording for the next slide or two. It's just this question and then a TIA. So if you want to leave, then feel free to just let me know. If not, and you just want to cover this last one, then have a read of the case.
Also, it's worth pointing out that if this came up in an exam, it would definitely be one of those stretch questions, like the ones that very few people get right.
I should get it right.
Because of my obsessions, not because I am good.
Because of both. So what do we think, before we answer the question, what do you think the most likely diagnosis is here? What do you think has caused this 32-year-old woman to have a stroke? It's not typical. And if you don't have any idea, that's fine. Just say, then we can.
The clue is it is once again rheumatological.
Is it? I could be wrong, but is this polycythemia vera?
So it's good. That is a very good guess, and it would be in the differential at this point, I think.
So is she hypercoagulable? Is that why she had a...
Yep, she is hypercoagulable. So well done. Any other suggestions from either of you? No worries if not. So, yeah, carry on.
Does ischemia cause hypercoagulability? I can't remember.
Yeah, I think it can. But what we're looking at here is a hypercoagulable young lady who has had recurrent miscarriages. And this is very suspicious for the antiphospholipid syndrome. So antiphospholipid is one of the core conditions in Mod B, rheum. And anytime you've got somebody with antiphospholipid, with these kind of symptoms, you want to check for antiphospholipid. So you want to do some blood tests to look for antiphospholipid antibodies, so the lupus anticoagulant, anticardiolipin, and the anti-beta-2 glycoprotein something. But I'll put these in the slides because I haven't put them in, or I'll do something else on antiphospholipid. But the answer here is A. Don't worry too much about this question, but I do think it would be useful if you just I will put the slides up, but if you screenshot it or something and look into why this is later. APTT, you would expect, if somebody's clotting a lot, you would expect the APTT to be short, but it's actually prolonged in antiphospholipid syndrome because the antiphospholipid antibodies, which stick to platelets and cause them to clot, that's why she's hypercoagulable, they react with the reagent in the test tube, and that means that the APTT is prolonged. So the answer would be A, but again, don't worry about that. And the final slide, what about TIAs? Well, a TIA, you can read this slide in your own time. Basically, a TIA is, people used to say it's basically a stroke that not a stroke, but neurological symptoms that resolve in 24 hours. There's not a great definition, nor is the new definition, which is no evidence of infarction on imaging, because not everybody who comes with a TIA gets immediately imaged. But suspect a TIA when you have amaurosis fugax, so when you've got the curtain over the eyes, or when you've got a brief period of, oh, I couldn't talk, my face was drooping for 5 minutes and it got better. Or, I found suddenly that I couldn't use my left leg for 5 minutes. And it'd be especially suspicious if people already have vascular risk factors. So things like hypertension, diabetes, all of that kind of stuff. Investigations, full neuro exam, blood glucose, ECG to look for AF, bloods, and a carotid Doppler. You also want to do a 24-hour ECG or a Holter monitor in anybody who presents with a stroke or TIA, and that's to look for paradoxical AF, which comes and goes. Management, if you're a GP, give them 300 milligrams of aspirin immediately, just like you would if they were having a heart attack, and refer them into hospital for urgent assessment. And I would recommend looking at the NICE guidelines for the exact timeframes, but generally it's same day or within 48 hours. And then you'd basically treat them the same as stroke. Optimize their cardiovascular factors, including lifestyle changes, give them clopidogrel lifelong, anticoagulate them if they've got AF, and refer them for a carotid endarterectomy within 2 weeks if they have over 70% carotid stenosis, and stop them driving for a month, because 1 in 12 people who have a TIA will end up having a stroke. And also some people can have TIAs that get worse and worse and worse, and those are called crescendo TIAs, and that signals to you they're going to have a stroke very soon, so make sure that you manage them. So that's the end of my bit of the presentation. Sorry we went on for a bit longer than the hour, but we did start a bit late. Anish is going to turn off the recording now, or I will turn off the recording. I'll do that.